Hello, classmates. We chose to address the topic of preoperative oral hydration therapy and how it relates to preoperative fasting. The purpose of preoperative fasting is to prevent aspiration during surgery. This is an excellent goal. However, the fasting period is often excessive and surpasses the recommendations of the American Society of Anesthesiologists. This is potentially harmful and unnecessary. To address this concern, we will follow the 4 foundational steps of the evidence-based practice process: ask, access, appraise, and apply. To define the problem, we formulated the following PICO question. In elective surgery patients, does oral rehydration solution administered up to 2 hours before surgery result in less than or equal gastric volumes recorded immediately after anesthesia induction compared with standard preoperative fasting from midnight prior to surgery? To access credible information, we searched CINAHL, PubMed, and Google Scholar with the keywords preoperative care, surgery, gastric volume, and preoperative fasting. In order to find the most current research results, we limited the publication dates to 2011 through 2016. We selected an article from the Journal of Anesthesia titled Safety and Efficacy of Oral Rehydration Therapy Until 2 Hours Before Surgery, a Multicenter Randomized Controlled Trial. Next, we began the appraisal process. The purpose of the study was to determine whether reduced fasting times plus administration of an oral rehydration solution could be implemented to improve the current practice. This article is a randomized controlled trial, which Melnick and Feinout-Overholt categorize as a level 2 on their hierarchy of evidence pyramid. And we used the rapid critical appraisal questions for randomized controlled trials to critique the article. A sample size of 274 participants was sufficient for the study. However, the exclusion criteria included 14 factors that could potentially limit the application to the general population. Next, we appraised internal and external validity and reliability. With internal validity, we found that the sample size and extensive exclusionary factors pointed to the interventions as the reason for the results. Unfortunately, it is possible that confounding factors may have influenced the study outcomes, and the authors did not delineate the categories of these confounders among other statistical data gathered, so we were not able to identify a pattern of use. When looking at external validity, a weakness was identified in the author's decision to exclude patients with a BMI over 35. The worldwide population has an obesity rate of 13%, which reduces the ability to apply the results on the general population. However, a study out of the Canadian Journal of Anesthesia found no significant difference in the gastric emptying times for fasting and non-fasting patients with a BMI greater than 30 and recommended that they follow the same fasting guidelines given to non-obese individuals. It is equally important to evaluate the reliability of a study. With a p-value less than 0.05, we can expect future studies to yield the same measurement of a fractional excretion of sodium and urea nitrogen, as well as the positive effect on the patient's feelings of hunger and thirst. We chose the Iowa model of evidence-based practice to promote quality care as our tool to implement change. First, we will form a team and execute a thorough search of the available research and design a plan of action. The first step we will take in our pilot of change is to provide training to staff members. Then we will create a flyer for the surgical patients detailing fasting recommendations based on research findings. Staff members will use this flyer during pre-operational education and will adjust it for individual patient needs. An important aspect of the flyer will be the inclusion of a phone number to call if clarification is needed. To evaluate the changes, we will distribute a staff survey to determine challenges that may arise. In order to identify weaknesses in the current flyer, we will gather the following patient information: patient questions or clarification needs obtained through the flyer phone number, and subjective patient reports obtained prior to surgery. Limitations we foresee in our pilot of change includes increased time spent customizing the fasting instructions for each patient. We acknowledge that change can be difficult and expect that issues related to staff cooperation may also arise. One of the greatest barriers we anticipate is overcoming the historical practice of fasting from midnight. It is vital to note that it has been nearly 2 decades since fasting guidelines were changed to include clear liquids up to 2 hours before surgery, yet patients are still enduring the practice of NPO from midnight. As Skolko and Pagnano state, fluid restriction intended to reduce the risk of aspiration promotes dehydration and may affect pain thresholds and response to anesthetic agents. Not only is fluid restriction an issue, but as Taniguchi and colleagues found, IV fluids are not a superior or even equal replacement for preoperative oral rehydration solutions. The patient who enters the operating room well hydrated and supplied with carbohydrates receives the most benefit. This is the primary driving force behind this change. Thank you for taking the time to listen to this presentation. We would be happy to answer any questions you may have.